Hello, everyone. I'm Dr. Carmen Puliafito, and I'm pleased to have with us today Professor Kevin Blinder of the Retina Institute at Washington University. Kevin, welcome to Retina Synthesis.
Well, Carmen, thank you for having me here today. I appreciate it. It's quite an honor and privilege to be involved in this process. So I think we're going to talk about steroids today, correct?
Right. You've done some very interesting work on the role of corticosteroids and the dexamethasone implant in particular for diabetic macular edema. And the way I'd like to start this session is to hear about your algorithm for treating a patient who presents to you for the first time with diabetic macular edema.
That's a great question. I think a few factors go into this. First, if it's marked edema, I'll be more aggressive with these patients. But if it's mild edema, we've been following them pretty closely. Not that much going on, but you can see a little thickening there. Then I might try some topical drops, corticosteroid drops, along with that non-steroidal anti-inflammatory drops to see if we can get some type of effect. Certainly, if they don't respond to this, I'll get more aggressive and go on to the intravitreal injections.
So, do you have a preferred anti-VEGF agent?
Well, and that depends also on the patients and their coverage. Certainly, if it was up to me, I'd do a branded drug every time right off the bat, but we aren't allowed that many times with step therapy. So a lot of times I'll start with a vast bevacizumab treatment to begin with. If we don't get a response to that, then I'll move on to the branded drugs, being certainly Eylea, Lucentis, or faricimab, Vabysmo. And Vabysmo has been very exciting, having the dual path blockage of the Ang2 as well as the VEGF. So very excited about that.
Have you tried it in diabetic macular edema?
I have, and I've had some very good results. So I think again, it's a individual response per patient, but yeah, I've had some very good success with that.
So what happens after you initiate therapy? How long do you continue with anti-VEGF? And when do you think about switching agents or adding a corticosteroid?
Oh, another great question. I think it depends on the response. If I get a good initial response, I might continue with the anti-VEGF for a while. If I don't get a great response after 3 injections, I'll either move on to different anti-VEGF or move on to the steroid.
So what are the indications for corticosteroids?
Well, I think that there's great use for steroids. First off, I'd like to just say, for diabetics in this country, Carmen, it's pretty amazing that we're near epidemic proportions for the incidence of diabetes in this country. 1 out of 5 people in the United States have diabetes. 1 out of 5 of those people don't know they have it. So it's really something that's near and dear to all of us, of course, as retina specialists. We see these patients all the time. And I think it's going to become more and more prevalent, unfortunately, with our sedentary lifestyles, our kids gaming inside rather than outside, with the type 2 diabetics going up in our adolescent patient population. So I think that we need to come up with better treatment regimens, better solutions. So we talked about the anti-VEGFs. I think that's certainly been a big boost to our treatment modalities for diabetic macular edema. But I think we also have to consider steroids. There's more that goes on that's released in diabetics due to the hyperglycemic state. They have VEGF release, but also they have other inflammatory cytokines that the anti-VEGFs don't get, and that's where the steroids come into play. So I think the steroid component is important to help change the blood retinal barrier disruption and help tighten up those tight junctions in our endothelial cells and reduce the leakage. So I think that steroids have a big role, or can play a big role in our armamentarium against diabetic macular edema.
So when you initiate dexamethasone, therapy. Will you continue anti-VEGF?
So I think that's a great question. Protocol I showed that steroids can be effective as ranibizumab. Is there concurrent action? I think there is. I think that that's something that a lot of people don't consider. I think that it's going to be a multimodality treatment regimen in many of our patients in the future. And so I think continuing the anti-VEGF agents, as well as introducing a steroid, be it a short-acting steroid or a longer-acting steroid, I think that can play a role. I think with our steroid use in the past, the delivery has been a big problem. We've tried topical steroids and the penetration is very questionable. Tried systemic steroids, and of course, we don't want our diabetic patients exposed to the systemic side effects of prednisone, systemic steroids. We've tried the subtenon Kenalog injections, which can be effective, but not, again, not as readily accessible as intravitreals. And we've tried intravitreal injection of triamcinolone. Again, protocol I looked at this, with some good success in pseudophakics. Problems with this intravitreal triamcinolone, the triesence has been difficult to obtain in the recent past. And then I don't like the pseudoendophthalmitis cases that you can get with these intravitreal triamcinolone injections. Can make it a little confusing. And then, of course, if you're not using the branded triesence and use triamcinolone, you pick up the vial and it says not for intraocular use is always a little intimidating thing to look at. So I've kind of abandoned using the intravitreal triamcinolone in these patients. The other option is suprachoroidal space injection. Xipere is approved for uveitis, macular edema secondary to uveitis. That is a possible option if they have a uveitic component to their DME. But for DME, straight DME treatment, it's really not an option. I think the biggest option, I think the most reliable option that I've had in the past has been the intravitreal dexamethasone implant. I think this has been a great innovation, and I've used it readily. This was secondary to the MEAD trial, as you know, that was ran from 2005 to 2012, and then was published by your good friend, my good friend, David Boyer in 2014 in ophthalmology. And just briefly, I don't want to go through all the details, but just briefly, this trial was well orchestrated. Looked at a 0.7 milligram dose versus a 0.35 milligram dose versus the control, a sham injection, 1-to-1 randomization of these patients, of over 1,000 patients, to look at the response to the treatment of diabetic macular edema. The patient population could have had prior treatment. Most of them did in the past with a washout, certain duration. And they were treated no more often than every 6 months. So if you ask me, I think they were undertreated in this trial. And even with the undertreatment and including the phakic patients, which are prone to cataract progression with intravitreal steroids, they still showed a significant improvement in vision, the primary endpoint, at 3-year duration. The 0.7 milligram dosage being much a better response than the 0.35%. And again, both of those being better than the sham. So this was something that showed a good response, and something that added to our armamentarium for treating diabetic macular edema. I can go into what we did with the data as well, Carmen, if you like.
Yeah, I'd like to hear about the retrospective review that you discussed recently.
Okay, yeah. So we presented this at Retina Society, and we decided to look at the data. We had all this data from the MEAD trial. We thought, well, what else can we try to look at and see what's going on exactly in these eyes? So we did a retrospective analysis to try to decide if the steroid effect helped to decrease the severity of the diabetic retinopathy progression, helped decrease it, halt it, or reverse it. So we looked at this data set, and we utilized the diabetic retinopathy severity scale that was used in other trials looking at DME in the past. This is really a scale that looks at, has 13 discrete levels for measuring diabetic retinopathy severity. And many times we simplify it. So we simplify this one and use a condensed 9-level DRSS scale to measure these patients. And then we looked at it with restricted mean survival time analysis to determine when the estimated time to the change of the DRSS levels occurred. And we found some interesting things. We looked to see again if this affected the severity of the treatment. So actually the patients that had the dexamethasone implants showed a 1-step improvement in the diabetic retinopathy severity scale scores about 2 months sooner than those that had the sham injections. Additionally, those that had a 2-step improvement in the DRSS score showed about a 1.5-month sooner change in the treatment arm versus a sham arm. So positive results in terms of slowing the progression and reversing the progression. And then when we looked at those converting from non-proliferative to proliferative changes, those that had the implants had a delayed conversion from proliferative diabetic retinopathy for the treatment arms versus a sham. So a delayed conversion from non-proliferative to proliferative diabetic retinopathy by about 2 months. When we looked at regression, proliferative diabetic retinopathy to non-proliferative changes, there was a faster regression in the treatment arm by about 1.5 months versus a sham arm. So it's very exciting data to show that not only was the dexamethasone implant, Ozurdex, effective treatment for diabetic macular edema, but also showed that it has positive results on the progression of the diabetic retinopathy overall. This was also shown by our good friend Charlie Wyckoff, part of this program, with the fluocinolone acetonide implants as well. This is another long-acting implant for diabetic macular edema that was looked at in the FAME trial, FAME A and B trials, looking at the effects of this implant on diabetic macular edema. And Charlie did a very similar analysis in this group of patients, showing again a slower progression of their diabetic retinopathy, actually some reversal as well. So I think that we've shown that this has occurred with anti-VEGFs in the past. This has been kind of a bonus in treating their DME or whatever we're trying to treat proliferative changes. We've shown that already, but it hasn't been as well orchestrated and demonstrated with the steroid injection. So I think this is something that we have to take into account when we're treating our patients.
Well, that's exciting results, particularly the change in the diabetic retinopathy severity score. Very impressive. Do you ever consider using the dexamethasone implant as a primary treatment in pseudophakic patients with DME?
I think that's a great option. It's not often thought of as the first-line drug, but I think that again in the MED trial, these were patients that already had treatment in the past, and they weren't treated probably as often as they should have been. So I think a first-line treatment may produce a more robust response in these patients. So I think it's a consideration.
Yeah, if you look at the protocol I data and subtract the cataract effect, steroids were as good as the VEGF agents, anti-VEGF agents, actually.
Right.
So,
Right. Yeah. That was one of the early trials to show us that, which is wonderful.
how long does the Ozurdex implant have a therapeutic effect in the eye?
Well, again, I think originally we were hoping for 6 months. So we don't get 6 months in the majority of patients, but I can usually get around 3, almost 4 months effect from these injections, which is pretty good.
Yeah, that's good. What about cataract and glaucoma?
Yeah, I think those are considerations. I think you have to tell your patients that are phakic, this may cause faster progression of your cataract. Yeah, I think that they need to know that. And fortunately, cataract formation is a treatable disease. So we have an option for that. We have a great treatment for that. In terms of glaucoma, I think that's a more serious matter. In the MEAT trial, they did show some sustained elevation of intraocular pressure with 3 patients having to undergo incisional therapy for glaucoma. So I think patients that already have glaucoma, I would be reluctant to treat at this point, or significant cupping of their optic nerve, or having had a steroid response in the past.
Well, you've discussed doing a trial of topical steroids to see whether or not the patient's a glaucoma responder. Are you still doing that?
I am. That may not be I think it's a pretty good test to see if they're going to be steroid responders. So again, a lot of times I'll consider doing a steroid challenge, just topical drops, along with a non-steroidal sometimes, to see if that has one, to see if we can have the option of using intravitreal steroids in the future, but 2, also sometimes we'll get some response clinically with their DME.
What topical steroid do you use?
So a lot of times, it depends on their insurance. Unfortunately, we always have to talk about that. But I like Lotemax SM, and I like Pred Forte. And then for the non-steroidals, I think it depends on their coverage, but Prolensa has been a good one.
What do you think the next step in terms of clinical trials with the dexamethasone implant are?
Well, we kind of looked at some combination therapy already with Protocol U, DRCR Protocol U. I think that personally, I still think combination therapy is going to be a good thing in the future. And then, of course, if we make an implant that has longer duration, I would love to see that as well. If we could do a Q6-month or Q-year injection for the dexamethasone, we already have for fluocinolone acetonide. Implants lasting a little longer, so maybe we can come up with a longer duration.
Well, this has been a great discussion. We concentrate on retinal pharmacotherapy, and this is really a very established treatment, and which needs to be discussed more frequently.
No, I agree, Carmen. I agree. That's why I was so happy to have you ask me on this program to discuss this matter.
Good. Thanks for joining us on Retina Synthesis. We hope to have you back in the near future. Thank you,
Thank
Kevin.
you, Carmen. Have a good day.